Well, good afternoon, everybody. Happy May Day. Today is May 1st, 2020. Welcome to the COVID Weekly Roundup for the California Association of Health Facilities. Today, we're going to cover a couple of different really emerging situations about testing and the implications that that has for our providers and emergency staffing and resources around that. So once again, if you have questions, we'll give you an email address that you can address those specifically, and we'll have a question and answer session at the end. So please, in the question box, go ahead and type your questions in, and we'll get to those at the end. My name's Jason Belden. I'm the Director of Emergency Preparedness and Physical Plant Services for the California Association of Health Facilities. And with me today is our guest speaker, Claire Enright. Claire is the Executive Director for the Quality Care Healthcare, or Claire, help me out. Quality Care Healthcare Foundation, is that, did I say that correctly?
No, but it is a mouthful. Quality Care Health Foundation,
there you go.
Is occasional arm for CAF. Okay,
there we go. So essentially, Claire runs our in-house education department. So the latest update today, first I want to start by giving my sincere apology. I gave a piece of information during the question and answer session last week that was incorrect, and it had changed in between the time that I had prepared the slides and the time that we presented the webinar. And I want to give you guys the correct information and also point you to where you can find information that's specific for you guys. CDC changed their definition of what a suspect case is for a healthcare worker that's exposed to COVID. And we had many questions about this because we have facilities that share staff in different buildings. And the question was, my staff works in another building where the other building has confirmed positive cases. And the CDC changed their definition of when a healthcare worker is considered a suspect case to be held out. And that change is pretty significantly different than what I had said on the webinar, and it's also different than what they had previously been recommending. So the current recommendation of who is considered a suspect case as a healthcare worker would be if that healthcare worker was working with confirmed COVID positive patients, they were in a 6-foot radius of that COVID positive patient without full PPE, then they would be considered a suspect case. Now that is the CDC's definition. You can find it in a footnote at the bottom of the description for healthcare workers. That is what the CDC guidance is. Local health departments are free to make their own guidance or recommendations or mandates, and the local health departments have varied widely on what they consider a suspect case for healthcare workers. So we know what the baseline is for CDC. That's changed. I highly recommend you reach out to your local health department or go onto your county public health website to see if you can find a definition of return to work criteria for healthcare workers. It can be completely different. I do know that the CDC has not changed their guidance for other countries. So that flow chart of holding people out with the definitive timeline, that still applies for other countries. It just does not apply for the United States. I don't know why, but it is different. So we'll see some of the local health departments use that old guidance, which is different than the new guidance. It's super confusing, and sadly, I may have confused more people than I helped. And so hopefully this gives you the correct information of how you determine what a suspect case is for potential healthcare workers exposed. But I just want you to have an understanding that your local health department can have a wildly different view of who is considered a suspect case. All right, and I wanted to just touch on the PPE because most of you guys have seen press conferences by not only our governor, but by the president yesterday talking about PPE and supplies being sent to skilled nursing facilities. So earlier this week, the state received the first of their purchased supplies, which they are now sending out to the counties that have submitted resource requests to the state. And then the counties will submit those out based on resource requests that they have received from you guys already. There's definitely a focus on getting skilled nursing facilities the PPE they need. How quickly we can get it there is still up in the air, but those supplies are on their way. In regard, I don't have a bullet point for the federal press conference from yesterday, but reading the FEMA guidance that was put out after that in response to it does not look like the 2 weeks of supply that are promised to skilled nursing facilities in our state are going to be in this first batch of supply distribution. Those supply distributions are going to be prioritized based on the metropolitan areas, which have the largest rates of spread. And even though we are profoundly impacted in parts of California, we still are not as even remotely as impacted as some of the other states and major metropolitan areas. So we anticipate maybe some of our larger areas, Los Angeles Basin and the Bay Area, would be second in that priority list because they have pretty large outbreaks in those communities. But when that is probably not going to be till the last part of May is my guess. It wasn't specific, but it stands to reason if it's going to be the middle of May before those first communities get it, maybe a week or two after that, we may get ours. The goal is to have all of the supplies delivered to every facility by July. I don't know how realistic that is based on our conversations with supply chain vendors. It's still not fully back up and running. The vendors that we've talked to have been able to pretty much meet their historical averages, but we're not in a historical average spot. We're needing thousands of times more than we would normally need. So we're still not where we need to be with the supply chain. So the second bullet point is unvetted vendors. And this could almost be combined with homemade or other kinds of PPE. We do know that some communities and some counties, because the resources are so limited, the counties have passed out lists of unvetted vendors that they cannot verify, whether these folks, they don't have experience with these vendors, but they anticipate the vendors are selling FDA approved items or items that are approved under the Emergency Use Authorization Act. So if you're in one of those counties that has those supply lists of vendors, that may be your next step if you can't get other stuff. And we know a number of vendors or a number of providers are making their own masks and things like that. Still continue to try to meet the needs with your existing supply chain. Don't spend all your resources on doing homemade stuff. As we get down the road later in this and we look back at this, we know that the effectiveness of those methods for providing personal protective equipment are not equivalent of the actual PPE. So keep trying to purchase the correct PPE and only use those homemade resources when you have nothing else. And then one provider in Los Angeles created a Google Doc where providers with specific supplies that were not necessarily within their need were delivered to them, but they were willing to share that if they could get supplies that they may need. So example would be, let's say you received a shipment of supplies of 1,000 large N95 masks, but that does not fit the needs of your entire building. And maybe you need some smalls and some mediums. So if you go onto that, the link on that form, and you're in that kind of Los Angeles basin, you can put in your information, and if you have a lot of one and none of another, maybe we can match you up with somebody else that does. This provider that did this is offering to do the logistical part of moving it around, or the coordination part of moving it around. So they've really gone out of their way to help everybody. You don't have to be a CAF member. It could be anybody can go onto that website and input that information. I think this is a good practice. We may try to replicate this in other areas where PPE is still a struggle, specifically the Bay Area and maybe even San Diego. We'd like to, it will require somebody to volunteer to help the coordination part of this. I don't know that, given CAF's current workflow and meeting immediate needs to the providers, makes it difficult for us to be able to coordinate it. But we'll try to create a PPA exchange form just like this, and we'll try to tailor it to the counties. All right, so I want to get to our one of our main topics today, and that is the wide scale testing. And depending on where you are in the state, you're going to hear more and more of this in the coming days and weeks to come. We know that multiple locations across the state are being set up to test healthcare workers. We also know that multiple counties are moving to test all residents and all staff in skilled nursing facilities. And so, gosh, what does that mean to us? There's serious implications to staffing. When we look at how our neighbors are dealing with this, let's say you are a provider in the Los Angeles basin, you know, San Bernardino, Riverside, Los Angeles, and to some extent Orange County. If you're in that area, you can look down the road and down the street, and you can see facilities that have done testing en masse, and you can see 10, 20, 30, 40, 50, 80 staff test positive that are completely asymptomatic. And that gives us an indication that there's some pretty substantial, you know, spread not only happening in our building, but there's something happening in our communities that's infecting the workers before they come into the building. So if you're in a community where you see a lot of community spread, it's logical to think that some of our staff are going to be impacted by that. And now we know that we should be masking everybody that comes into our building. But up until a couple of weeks ago, that was not the recommendation. As a matter of fact, the recommendation was the opposite. It was to preserve your masks for the symptomatic people. Now we know that was probably a mistake, and that's what contributed to these large outbreaks. But when you look to your neighbors, you can see, oh gosh, there's a bunch of them in my community. It's logical to assume, if you've not done testing, that it could be in your building as well. And so we know we want to make sure that everybody's masked, and that happens. The expectation from everybody, from the counties, from the mutual aid regions, from the state, everybody wants you to stay operational, regardless of how many people test positive, how many staff or residents test positive. The expectation is you're going to stay operational. We don't, nobody wants to see you guys have to evacuate simply because a bunch of your staff turn positive and can no longer work for a few weeks. So how can we support that, and how can the county support that? So, well, I'll give you an idea of what has happened, and we've seen this happen in different ways across the county. We've seen it happen poorly in the instance of the facility in Riverside, which was forced to evacuate, and we've seen instances where hospitals had to be the support function for a facility to keep them from evacuating. Those are two situations that are not ideal. So how can we get you to be supported in your building without taking away from other healthcare facilities? And so kind of the goal going forward is essentially when you start testing in mass, you're going to need staffing resources quickly, because what's going to happen is you're going to get the results back and you're going to have a few staff that are going to have to stay gone. And those folks will need to be replaced pretty darn quickly. So what can you do now in order to address that need? So if you have staffing agencies that you work with and have worked with in the past, start with those folks, engage them, assess their ability to help you. How many staff do they have? Have they sent all their staff to support operations somewhere else? So assess what their capacity is to help. Be specific with the types of staff, when you need the staff, what staffing models you'll need help with. That's the first part. If you have mutual aid agreements, whether it's with internally with your, if you're part of a chain, internally, do you have mutual aid agreements to bring staff in? We obviously have concerns about healthcare workers being exposed in COVID positive buildings. So you want to do it in conjunction with your county, but that could be another method that we could explore internally to support our own operations. And then Claire's going to talk about alternate staffing models and all these other things that we can do for our own internal resources. And what you should do if your local health department and MOAC are not fully engaged when you start the testing process, they need to be told and made aware that, hey, we're beginning to test all of our staff and all of our residents right now. That gives them the situational awareness and understanding that maybe in 24 to 48 hours, when those results come back, they're going to have immediate staff to send to you. So how do you get those staff when you've identified the need? There's a very specific resource requesting process. It's covered in an AFL 2046. We've talked about it before, but the process looks identical to requesting PPE supplies from your local MOAC. There's an Excel spreadsheet that's located on our website. It has different categories. One is for PPE, one is for staff, one is, there are different categories within that spreadsheet. When you request staffing, you need to be very specific about the type of staffing you need. You can't say I need licensed staff and I needed unlicensed staff. You need to say I need 4 CNAs for the knock shift, or I need 3 RNs for here, or I need 1 LVN for here. You need to be specific with what your actual needs are. Now, whether they can meet those needs with the exact type of personnel, we don't know that yet. You may get a team of EMTs and a team of RNs, and that may be what you get. That may be all that they can send you, but be specific in your request, because they will try to marry up a scope of work with the staff they're sending. So with an EMT, we'll talk about what that looks like in our building, what they can do, and things like that. But that's the process for requesting these emergency staffing needs. Now, if you're getting ready to evacuate, or you need staff just to provide minimal care within 24 hours, don't send the form in. Well, you could send the form in, but also make a call to the MOAC and ask them and tell them how serious this is. We've got to be the squeaky wheel when it comes to this, because if you're not, the focus may not be as great as it needs to be. So we need to, if it's that important, you need to pick up the phone and make a call to these folks. All right. So the expectations for residents that turn positive is to keep those folks in the building. That's the expectation. Unless they're acutely ill and they need to be transferred to a hospital, the expectation, now it depends on the county, But most of the counties, the expectation is that you're going to continue to maintain that person in your facility. That's given in the CDPH guidance, and most of the counties' guidance follows suit. My recommendation is to create messaging to the residents and staff prior to starting your testing process. Think about how you're going to talk to them about, the fear that's present when you start this testing. Engage with your staff quickly. I know this is, it's not, I don't want to say it's low risk for our staff members, but clearly it has less risk for our staff members than it does for our residents. So allay some of that fear and let them know, provided they're not one of the high risk folks, if they're a high risk staff member with underlying health conditions, or they're over 65, they have reason to be a little more concerned than somebody that's 27 and that's working in your building. But be realistic about, what happens if they do test positive, what your pay policy is to have them stay at home, things like that, that will help assuage some of the fear that your staff is going to feel prior to the testing, because there's going to be a lot of anxiety waiting for those results. Like I said, the expectation is that you stay operational, know how to use those lifelines to get those emergency staffing resources in there to help provide safe care. So what has happened and what can happen? So we know that when these large outbreaks happen, we're going to have some folks that decompensate pretty quickly, and those folks are going to need to go to acute services. But how do we support the folks that have mild symptoms or have no symptoms? We've got to have a plan to cohort residents in our facility by their testing status. And we've talked to you about setting up a observational wing or a transitional space to deal with untested, asymptomatic admissions from hospitals. Those are the spots where you need to think about, that's where we're going to cohort folks. You're going to have, and just because we get one negative test doesn't necessarily mean everybody's confirmed negative, but it will give us a head start. We'll at least have identified a good portion of the building that is positive. And those folks are going to have to go into those spaces that you have designated. Talk to your staff. If we have a bunch of positive cases, how many of you guys are willing to work with COVID-only residents? How many of you guys, if you test positive, are willing to come in and work the COVID-only residents? Create messaging to the families of the residents now. Explain to them, that you're doing this as a precaution and you want to protect everybody that you can. And we know that you are going to get inundated with media requests as a result of this testing stuff. It's happened in multiple counties. Our media relations department deals with dozens of media requests every day asking for names of facilities specifically that they can contact. It is not our point to marry those people up with you guys. We're not in the business of doing that, but I just want you guys to be understanding that if a media person calls you, you may want to have a plan in place to deal with that, whether it's talking points that you want to give to your folks, whether you have a designated PIO or somebody that's going to deal with the media, or if you have a corporate person that can do that, have that ready to go now. Provide situational awareness. Most of the time, this is going to be done in conjunction with your local health department, but your MOOC is a separate function. And generally, the MOOC is run by the EMS agency at a county level, and the local health department is run by public health at a county level. Sometimes the two departments talk, and sometimes they are not as in conjunction. And so make them both aware that you're starting to test all of your residents now. And they understand what that impact can mean to not only staffing, but PPE and space. And so those folks, if you let them know that you're doing it, that will help them in their planning process for if it goes sideways. And the last point I want to make about this is making lemonade out of lemons. We've talked to a number of providers that have had large outbreaks that have now turned their buildings into partially COVID buildings or full COVID buildings. And I leave that up to you to determine what to do. But if after you have an outbreak and you can have public health come out and support you with infection control guidance, whatever information you need to be able to successfully deal with taking care of COVID positive patients, that's in the best interest of everybody. And so we've seen public health departments go out and do that. And when it works really well. And you can reach out to providers that have done this. There are providers that are actively doing this. My hope is to get a few of them on a webinar next week so we can talk about how they made lemonade out of lemons. But it really revolves around our cohorting plans. And sorry, I skipped ahead one too long. We have, if you're looking for guidance on, gosh, how do I cohort, or how do I set up a transitional space, or how do I take care of COVID positive people? If you go on the CAF disaster preparedness website, cafdisasterprep.com/pandemic, the very first link, I believe, is a cohorting, some cohorting procedures. Go ahead and print that off. It's a PDF version. You can check that out. But these are all of the components that we would suggest that you do in the setup of your either transitional space or your COVID positive space. These are items like, obviously we're going to keep them separate from the folks that don't have COVID, but it's talking about a staffing model that's consistent. Supplies have to be in a separate location, clean and soiled laundry, different locations, garbage cans for the collection of PPEs, separate staff respite areas for people working in the COVID building and the non-COVID part. All of those things go into doing it safely. And that's based on information provided by the CDC ground teams that have gone out to these outbreak facilities at the beginning of the COVID response. So it's borne out by experience from folks that have gone through these lessons, and I highly recommend you take a look at that to make sure it marries up with what you've already done. And if you have suggestions, we're open for this. This is a workbook, and we all need to be better. All of us can help each other out with this. So if you have information that you think is important that needs to be added onto that, please send those suggestions to me. All right, I think I've gotten through the wide scale testing part of this, and now I want to bring on Claire, and Claire's going to talk about more of the workforce in general and some of the things we can do related around that. Claire?
Hey, it's good to be with everybody. I kind of miss everyone, and I see there's like over 100. Oh, there's over 200 people listening. So take a deep breath. I know you're in the middle of a crisis. Hopefully things are stabilizing around you. Some of the counties and some of the areas haven't been hit hard yet. Hopefully, knock on wood, you won't be. But now with everybody getting tested and the mandated testing coming out as it rolls out, or it might not even be mandated, but as it comes to your community and your staff is getting tested, it is going to affect how your staffing goes. The bottom line is we've already been stressed for staffing way before this ever started, and I'm very aware of that. But right now, we're just going to concentrate on how to get through your immediate needs. Jason's already discussed a lot of this in detail, so I'm going to just kind of slide over this first slide, but I just want to remind you that take a minute to prepare before this all goes down. Have a plan. Be very straightforward with your staff. remember that there's, housekeepers and laundry people that are kind of out of the flow, and they're going to get tested at some point and really freak out. So make sure that they understand that you're developing a safety net of some sort for them. And by a safety net, I mean that you've thought about what you're going to do if half your staff has to go out in quarantine. I want to bring to your attention AFL 2045, which does provide healthcare workers with hotels. It's not necessarily free, but the state of California is assisting on this. If you go to that AFL, you'll find that there's also a template letter attached to it that needs to be signed by a medical director. And again, have this ready to go. And no, I mean, you're not going to know where you're going to be sending them, but it will be a local place. It will be close to the facility. You can also use this even if your people aren't necessarily testing positive, but if they've been exposed, or if they're having a hard time coming to work because they have people in their home that they don't want to expose at all. So this is a space for you to access for them, to give them support. The other thing is to start looking at your schedules and your assignment changes. Again, you've been through this before. That norovirus that hit 2 years ago and wiped out all the staff, you know exactly how to deal with it. It's just a matter of doing it and keeping your wits about you and letting staff know that you've got their back and that you're going to work with them, and hopefully they will work with you in return. So you can move on to the next slide, Jace. Thank you. So this is all about being proactive. Before you call the MOOC, before you go into emergency mode, make sure that you've, set yourself up for success. So call your local registries. I know some regions don't have strong registries, but make sure you've made contact. Make sure you have contracts with them. Believe you me, the guy that doesn't have the contract is going to get the last service versus the person that has a contract up and running. So take the time now to execute that and figure out who can do what for you. Get your creative staffing thoughts out. Do you have people that could go back and forth as far as cross-training? I know as a DON, I used to have to do laundry every once in a while. I know how to run the laundry. Do all of you know how to run the laundry? I'm sure your administrators do, but think about that kind of stuff. We know that our dietary, housekeeping, and laundry staff is going to get hit with this just as much as our clinical staff. And like I said earlier, we need to make sure that we really keep them in the loop and give them a lot of support, because chances are they don't have as much insight. And clinical staff, well, thankfully the state has given us a bit of wiggle room, and you have potential now to think outside the box and access some staff members, potential staff that you don't usually think of. And I'm going to mention a few. If you have some that I have forgotten, don't hesitate to tell me. Where to go? You have local resources. Again, this is not what you're going to do in the middle of the crisis. Hopefully you're doing this proactively. It's going to take some time. It's going to take utilizing different people on your team. There might be people that already have an association with some of these resources. Obviously, you're going to tap into them first. But for dietary, local hotels, restaurants, and schools, I'm part of an association that deals with associations, and the local hotel and hospitality associations are worried sick about their workers. So there you go. Laundry, housekeeping, and dietary coming out of the hotel industry is they've got a bunch of labor that needs to find a place to work. So that's the first place I'd look. Also, community colleges, dietary and food service programs, a lot of them are freaking out right now because they don't have a place for their clinical rotations, and they need to get their clinical hours. So reaching out to them could provide you with some boots on the ground. Also, the temporarily closed schools and dorms for laundry and housekeeping. It used to be that we had a really hard time finding staff because We didn't have any unemployment. Well, there's now a glut. It's just about taking the time to find people and hopefully finding people that are already trained. Next slide. So here is some of your community networks that you already have. And for your clinical staff, you can now use, like I said, this is a limited list, medical assistants, EMTs, home health aides, and student nurses. You can't use them as, quote, CNAs, because in California, you either are or you're not a CNA. And no, the state has not okayed the temporary NA, which a lot of other states have rallied around. But that doesn't mean that you can't use alternative caregivers. We're not going to get a definition. We're probably not even going to get an AFL from the state about how to utilize these people. But if you go to their certification boards, like the Department of Consumer Affairs, you'll find that they've given us waivers and abilities to use these people out of their routine workplaces. When you go to use some of these people, think about how you're going to bring them on board. If you wait and you have emergency people, teams hitting you, served from outside of your facility through emergency services, they're a little bit different. You're still going to have to do some kind of an orientation, just like when you use a registry. You still want them to feel like they know where the linen closets are and where the gas shutoff is. But that's still very, quick and fast, and not necessarily to the level that you want when you have staff working in your building, especially in a stressful time. Hopefully, you're going to be able to reach out to the individuals that I've just pointed out to you and be able to bring them on board in a reasonable fashion, calmly, and get them secured into their space so that you can trust them and they can trust you. Some of them all of them, you're going to have to do some kind of a skills checklist. You probably are going to have to do some kind of a policy and procedure to, or at least some kind of a procedure that you can maintain to put into your emergency kit that will demonstrate, if God forbid you're surveyed down the road, about how you vetted these people and got them in as caregivers. Just have a plan. I don't have a template for you to follow, but I'm sure that you already have job descriptions, et cetera, that you can alter and kind of tack these people into it. Where are you going to find them? You already have, as a facility, these resources in your community that you access all the time, or they access you. You talk to your acute care hospitals. A lot of them are laying people off. So there's a great place to look. Physician offices, outpatient surgical centers, home health agencies, ambulance and transport companies. You have some form of relationship with all of those people. And all of them have staff that are being underutilized right now or already furloughed. How you go about reaching out to them, I would personally use the staff member that has the established relationship. I'd approach them with the idea of what we need, how long we need them for, how we're going to utilize them, and then ask for some kindness, generosity, and telephone numbers so you can reach out to these people. Next slide. Some of the thinking outside of the box is actually going to your local nursing schools, LVN and RN. The Department of Consumer Affairs has brought up some waivers that they've put in place to use student nurses. Again, you're not going to call them CNAs, but they have scopes of practice that they can work to. I didn't include it here, but I will give it to you right now. It's the Department of Consumer Affairs memorandum that came out April 9th, 2020, and it's a waiver of restriction. Another attached or embedded link in that gives a cross-section of theory classes and clinical rotations that student nurses have taken and what skill set they should be able to perform for you. CDPH has not come out with this waiver. This is a Department of Consumer Affairs waiver. Just remembering that you're going to go to different places to get different information. The other thing to remember about flexibility that I didn't include in the slide, but I'm going to give it to you, is using emergency medical, it's called the Emergency Medical Services Authority. It is a memorandum that came out March 24th, 2020, and it refers to the authorization of using out-of-state medical personnel. So if you have a large corp and if you can't pull people from out of state, or if you're doing it on your own, you can get that reciprocity waived relatively quickly and use that. So talking about community-based nurse assistant program. If you're lucky enough to have an in-house training program, you have the ability to hire people and use them as NAs now for an extended period of time. No longer do you have to have them done within 3 months. You can extend that through the course of the emergency. You can bring them in, do bare minimum training to whatever you have time for, and then start your program as you stabilize, using those NAs to their skill level. If you do not have your own program, you have the ability to pull in community-based training programs, NAs. If you have a relationship, an existing relationship with a community-based program, call them. They probably have students or wannabe students that you could probably hire. And here is one of the caveats. If you go to your 280A form, that's the form that you get back from CDPH that tells you that you've been approved for your orientation and ongoing CEs that you have to give to your CNA, that form. And within that form, on the right side, top right side, there's a box that says whether you can only hire CNAs or if you can hire NAs. At this point, you can ask for a waiver, a 500A form, to flex that 280 form so that you can hire NAs. That way, you can contact your community-based program and you can get NAs to come in. The beauty about what has happened is AFL 2040 gives the programs flexibility on how they're going to provide training and education. So they can go online, they can do all sorts of different things with minimal effort on their part. Not to say that turning your curriculum on its toes and teaching online versus in person is an easy task, but they have the ability to do it. A lot of the community facilities put themselves on hold because they didn't have access to clinical sites anymore. So if you call them and say, I have a need for 10 new CNAs, you might be able to get them relatively quickly. That's all I have.
Well, thanks so much, Claire. I just want to mention one thing on the EMTs that we found out that not every county is doing that. And it seems like it's a county by county decision to ask for permission to use EMTs. LA County has produced like a scope of work for an EMT when they go into a skilled nursing facility. Of course, that just applies for that county. And I'm certain that the counties that are currently using it have some kind of scope of work for the EMTs. My point is, before you count on them as a resource, confirm with your individual county that they have received authority to be able to use them. So
thank you, Jason. there's only one county so far I've heard that hasn't done it. You might know of more, but I've heard that it's actually being well received in most spots. But very good point.
Yeah.
Make sure your county's allowing it.
Yeah. And it's just another one of these items that kind of highlights the fact that we have to really work in conjunction with the folks from our local health department and local EMS agency. The only way we're going to get through this is through a coordinated response hand in hand with those folks. And the better our working relationship with them is, the better it's going to turn out for our residents. So that's the rest of our session. Hopefully we have some questions here. I don't have the question box, but maybe Courtney, can you read out any questions for us?
Yes. So our first question is related to RCFEs. It says a lot of assisted living RCFEs who are our rural source are hurting, and there's stimulus funding for them.
Hey, Courtney, Courtney, can you do me a favor? Something is going on with your, there's a lot of feedback on your phone there. See if you can. And then try to ask the question one more time for me.
Hey, Jason, I'll give you a question here while Courtney gets that figured out.
Okay, sure.
Question here, a lot of assisted living RCFE who are our referral source are hurting, and there is no stimulus funding for them. Some of our partners take Medi-Cal waiver patients, and they want to know if CAF can assist them to get the funding.
That would have to be done by either CALA or Leading Age. We don't represent those folks. We don't even have an avenue to advocate for them. But both the California Assisted Living Association and Leading Age, CALA probably represents the majority of the providers, and Leading Age maybe another portion of it. But those two folks are, to my knowledge, are advocating both at a local level, state level, and a federal level. Next question.
Okay. Is it okay to use the cloth masks as a preventative measure if there are no known COVID-19 residents or staff, or should we use surgical masks instead for this?
Yeah, the guidance is surgical masks. Homemade masks or cloth masks have not proven effective, and there is, even when you look at when we go into the crisis stages, I'm not even sure that it talks about that as have any kind of effectiveness in the transmission. Now, that's a government agency saying that because they can't, they can't say, well, it'll give you a 70% protection. So, right, they either say yes or no. Use your best judgment. If that's all you have, that's what you have to use. But if you have other options that are in the form of traditional PPE, we use those first and only move to other options outside of a lack of nothing. So, next question.
Great.
This is Courtney. Can you guys hear me now? Is this any better?
Oh, much better. Thank you.
Okay, great. Thank you, Jamie. So I will go ahead and do the next question here. Shida is asking, could you please summarize how many entities we need to report COVID-19 to? So far, CDPH, the local public health department, CMS, CDC, etc. Are there any other ones?
The list keeps growing by the day. I don't know, we might find a new government agency to report to next week. But at the moment, we know that your local public health is doing, each public health department, and there are 61 of them, have different procedures to gather situational awareness. We know that CDPH has the online form, and that's still an expectation that everybody once a day goes in and inputs that information. That's really important. The CDC is going to come out, and that is going to be a once a week survey, I believe. So it won't be as bad as doing a daily survey, but whatever the local health department requires of you, you have to do because that's their jurisdiction. CDPH is trying to combine both the CMS data and the data they want into one form, and they will give that information to CMS. That's the goal. And then we don't know what's going to be in the CDC questionnaire yet, or the survey. We have some of the stuff. We're working with CDPH to see if we can come up with one survey that incorporates all the questions, and that CDPH could be the person that funnels that information. From an operational standpoint, it makes this much easier for us to comply with one or two than three or four. We're hopeful that they listen to our concerns. They did address it with the CMS requirements pretty quickly. Depending on how detailed the CDC wants the information, it may be we can roll it into the CDPH survey. That's the goal, and that's what we're advocating for. Whether it happens or not, we shall see. So more on that to come. But yes, at the moment, it's CDPH, CDC, and whatever your local health department requires. Next question.
Yes. Patricia wants to know, is it mandatory that we test all staff?
Well, it's not mandatory, but I say that because each county is different. I think we're really close within the next couple days that you're going to see massive mandates to test everybody in a skilled nursing facility, staff and residents included. And that is why most of our presentation today was about preparing for what the consequences of that are. If you have a staff member that refuses to get tested, I don't know how to deal with that. I suppose I can find that information out, but expect it to happen. Now, if you're in a more rural area of the state that has less impact, maybe it's not as big a priority to them, or maybe they don't have the testing resources to go out and test a couple hundred people at once. It's highly dependent on the local health department that you are in, because we've seen vastly different views on how to test folks just cross one county line to another. So this is one of those ones I got to punt and have you contact the local health department, but expect something like that to come along soon, and sooner than later, for communities that have large outbreaks. Los Angeles area, obviously the Bay Area. Those are the areas we anticipate you're going to see a massive push to mandate testing for everybody in a SNF, including staff. Next question.
One provider wants to know, if an employee decides to stay in a hotel to self-quarantine or due to positive COVID testing, is it an out-of-pocket expense from the employee, or will the state or facility pay for costs?
Claire, are you still on the line?
Yeah, I'm here.
So that, I was just going to say that one program, yeah.
Yeah, there is the state does have a program. They word it as it's not necessarily free, but low cost. And you know, I can't help but not put in a thing about workforce culture in here. Asking a minimum wage employee to chip in the cost for a hotel may not be the best thing to do to demonstrate your support of your staff. That said, it's also understandable that if you've got 20 people needing to stay in a hotel, that no facility wants to bear that burden, or maybe even can bear that burden. So I would, again, proactively do as much research as I could with how much I am going to get charged, or the charge will be. I'd also make sure to double check to make sure that that employee is choosing quarantine for the reason that they would be covered under the state's AFL. It's not just helter-skelter. There's some fairly distinct qualifiers to enable you to get the that resource, access to that resource. I hope that helps.
No, I think that was perfect. You had a better info than I do, for sure. Next question, Courtney.
Yes. Are consents required for testing residents? What happens if a resident refuses?
Well, I assume that is within their right, but you know, I don't know that they can mandate it, but I'll have to check and get an answer for you on that. I know it's been addressed. I just don't have the information off the top of my head. Next
Okay,
question.
one more question. My facility was tested. Staff that refused are considered positive asymptomatic and can only work with positive COVID patients. Oh, I guess this was more of a statement. Does that sound correct with what's going on does that jive with the current guidance?
Yeah, so, well, I mean, I don't know. Like I said, the current guidance for what's considered a suspect case differs by the county. If the county's saying that because they refused the test, they consider them a suspect case, if that is how the local health department interprets it, then it's true. They could only work with the COVID positive folks after that. So they don't want suspect workers working with COVID naive, and they don't want COVID positive staff working with COVID naive folks. So if it really revolves around what their definition of a suspect case is. I don't, as for what their ability to refuse the test is, I mean, I guess that's within their right. Like I said, I don't know that we can force anybody, resident or staff, to get a test. But I will have to check to see if that's true. Any more questions, Courtney?
Yeah, the last one comes from Melinda. Why are they pushing to test all staff and residents if everyone in the building is asymptomatic? All staff is wearing masks in the facility and in the community.
That's a great question, and certainly it's one that has merit, because there are so many so many other things that can happen when we come in and test a building and the folks are asymptomatic. Staffing challenges, PPE now needs to change. All of that stuff needs to change. The reality is, though, we could have 80 people that could test positive for this and have mild symptoms, and we've seen that happen in other buildings where we've had outbreaks where few have had real serious impacts from that. But that doesn't change the fact that some of our folks will, if they get this, it's fatal. And it's a pretty high percentage in the aggregate. And so maybe you have 10 asymptomatic people that you uncover. And for those 10 people, it's fine. But if we can isolate those people and put them in that transitional space and treat them with separate space, staff, and stuff, then we give the other people in the building the best chance of not being infected. And that is the important part, because we can't identify who is going to have problems with this. We just know that in general, the people in our building don't do so well with this. And so if we can identify the people that are positive, staff and residents included, we can thoughtfully think about how we protect the remainder of the folks that have not had this, staff and residents included. So even though we look at testing as maybe we're uncovering something, a problem we didn't think we had, it's better than having 10 or 12 residents rapidly decompensate all of a sudden, which has happened countless times. Because the way this works is we could go from no symptoms to being really sick in a couple hours. And that is borne out by the morbidity and mortality reports that are released by the CDC. In our population group, they may not display symptoms until they're really sick, and then they need immediate interventions. So we want to avoid that. Just because they're asymptomatic doesn't mean everybody's going to be asymptomatic. So, any more questions, Courtney?
Yeah, we have a few more. Do you want to do? Okay,
yeah,
we'll keep going.
Yep.
So we had another follow-up question. So just to clarify, if it's mandated to get tested, can an employee still refuse to be tested?
Like I said, in that jurisdiction, that was a great example of somebody refusing to get tested and the local health department having a policy to deal with the folks that refuse. It sounds like that is probably a a good policy for a local health department to have, that if a staff member refuses to get tested. I don't know what to do about that. I mean, if I was a staff member, I would want to know. I would try to have conversations with your staff that if they care about the residents that they deal with, that it's important to find out if you could unknowingly be hurting the people that you care for. And that, if you explain it to them that way, these are people that we care for every day. We care immensely about how they do in our buildings. We don't want to contribute to them getting sick. And through no fault of their own, many healthcare workers have done just that, simply because we gave them the wrong guidance. And I don't think that's the goal of anybody that works in a skilled nursing facility. So I understand their hesitancy to be tested, but I would say, listen, if the option is you can't work, then, you know, or you're going to put somebody else at risk, please, you know, go through the test. I would do it. I'm expecting you guys to all do it, you know. So I do think it's a method of giving us information we wouldn't otherwise have, which could influence the safe care of the people in our building. Next question.
If an employee tests positive and asymptomatic, will public health require a negative test for the employee? Currently, the guidelines between public health and licensing are different.
Well, my assumption is that if the CDC guidance is, okay, you test positive, but you're asymptomatic, you stay out a set period of time. Each local health department has moved that barrier depending on their local need. And it has even changed from conservative to less conservative to more conservative as we've gone on. That's one of those things you have to be in contact with the local health department, because some are 14 days, some are 10 days, some say you can come to work and work only with COVID positive. So, you know, it is really across the board. CDPH has given a baseline, but the local health departments can choose whatever they want to do. Then next question.
Okay, I think this will be our last question for today. What is the point of publicly publishing facility infection rates? Who does it help? What's the ultimate goal for pushing that data to the public?
Well, that's a great question. It's certainly, I mean, the collection of data in the aggregate is great, especially if we can narrow it down in geographic regions. We can help use it in the planning process of moving resources to be prepared to meet immediate and emergent needs. That's why you do a survey. Now, why CDPH is publishing that survey, it has all to do with public pressure. You know, there's advocates and there's folks on in the public side who look at skilled nursing in a different way than we look at it as working in this profession. And sometimes we don't always win those fights. And that's one of those instances where not only did they do it in a vacuum, they did it without telling us, and it happened without our preparation for the release of all this information. We got like a 2-day notice essentially, but we did not even get a chance to advocate to not publicize the information. All right, guys. Well, I appreciate all the questions and you guys hanging out. Thanks so much for hanging in there and for all that you do to support the folks in our buildings. If you have any questions, please don't hesitate to go to the CAF.org coronavirus website or the CAF disaster prep website that I quoted earlier, and email any questions you may have going forward. So thanks very much, guys, and have a great day.